Good day. I am Dr. Carissa Marie Baker Smith, and I want to welcome everyone to Healthy Churches 2030. We have an exciting lineup of speakers meant to inform you about preventing acquired cardiovascular disease. I am a pediatric cardiologist and will present a topic of familial hypercholesterolemia, why knowing your numbers matters. I will be followed by Dr. Aisha Mustafa, who is a cardiology fellow at Emory University School of Medicine, who will be talking to you about hypertension and achieving adequate control to reduce the risk for cardiovascular disease, followed by Dr. Sabrina Islam, who will talk about CAC scoring, which is coronary artery calcium scoring for cardiovascular risk assessment. To start things off, I will begin by talking about familial hypercholesterolemia and why knowing your numbers matters. And again, my name is Dr. Carissa Marie Baker Smith. I am an associate professor of pediatric cardiology and director of the Pediatric Preventive Cardiology Program at Nemours Children's Hospital in Wilmington, Delaware. These are my disclosures. I am, in fact, a consultant for Merck Pharmaceuticals for a medication that is not described in this topic in this presentation, and I also served as a site primary investigator for a medication called evinacumab, which again I do not discuss in detail in this presentation. So I want to begin just by setting the tone. Unfortunately, I had the pleasure, but the also witnessed the misfortune of a close colleague who unfortunately suffered a myocardial infarction at a very young age. She was 37 when she experienced a heart attack and had thought to have been otherwise healthy. However, the cause of her myocardial infarction was familial hypercholesterolemia. And so the objectives of this presentation are I hope that everyone who listens to this talk understands a few things. But what I really hope that you take away from this is health literacy about a preventable cause of premature heart disease. But we will review familial hypercholesterolemia, what is familial hypercholesterolemia, when you should consider that you or a loved one has familial hypercholesterolemia, how is it diagnosed, how is it treated, why is it treated, and why diet alone is often insufficient, and then we'll continue with a case discussion. So, first and foremost, what is health literacy? Health literacy is access to health information, which is part of the goal of this session, understanding health information. But then my goal for everyone who listens to this presentation is to then be able to use this information and services to promote and maintain good health. Familial hypercholesterolemia, or FH, is an inherited cause of high cholesterol. That means it's not because of diet. It's in fact a part of the individual's genetic makeup. We all have genes that code for proteins that determine what we look like, our nose shape, our hair color, our height. But in this case, mutations that are associated with the inability to clear the naturally made cholesterol that we all make. Unfortunately, the complication of FH is premature coronary artery disease or heart attack before 55 years of age in men or before 65 years of age or premenopausal in women. FH is a genetic condition. Like I said, it's inherited and it causes high cholesterol. And when left untreated, heart attacks do happen. 30% by age 60, 50% by age 50. So finding and treating familial hypercholesterolemia early reduces coronary artery disease risk and reduces its risk significantly by as much as 80%. So I promise you that this presentation will not be filled with complex terms and lots of pictures and graphs that you have trouble understanding, but I do want to highlight a few key points. One is that cholesterol is made, that it's synthesized in the liver, and that it is responsible, that the liver is also responsible for removing that extra cholesterol from the bloodstream through something called the LDL receptor. Now, the LDL receptor is a protein itself that is responsible for moving extra cholesterol from the blood. But when someone has a poorly functioning LDL receptor, as occurs in 70% of individuals who have familial hypercholesterolemia, these individuals are not able to remove the cholesterol normally, and it builds up in the blood. There are some other mutations that are associated um, with familial hypercholesterolemia, PCSK9, gain of function mutations, meaning think about that can of muffin mix in your, or the box of muffin mix rather, in your cabinet. You get rid of it by putting it in the trash, right? If it's expired. Well, PCSK9, that's its job. It gets rid of that box of muffin mix. However, if overactive, you won't have the muffin mix that you need. An overactive PCSK9 means that you don't have the receptors that you need to remove the naturally made cholesterol that needs to be removed from the bloodstream when it needs to be removed. ApoB is another mutation associated with familial hypercholesterolemia, much rarer, but it's like the white part of the Oreo cookie. It helps keep things to stick together. It helps the LDL to stick, if you would, to the LDL receptor. And then when not present or absent, then the body's unable again to clear the LDL cholesterol from the blood normally. And then there's an autosomal recessive form, which is a rarer form of hypercholesterolemia. And about 23% of individuals, we never identify the mutation for FH, but we do in fact know that the individual has FH. So again, just like I won't bore you with lots of graphics with complex diagrams, I do though want you to understand that this process of atherosclerosis, which is the buildup of lipid and thrombotic agents and other clotting agents into the walls of the artery occurs over time. And it is when that rupture occurs of that atheroma that we get this downstream debris that clogs off the artery. Think about your drive home. You start to see the cars slowing, and then everything comes to a stop. That's what happens in the blood vessels. And that's as a result of having high cholesterol for decades. How do you know if you have FH? Well, first you check. There's really There are many individuals who have no outward signs of FH, but their cholesterol levels are very high. And LDL cholesterol in adults or children greater than or equal to 190, that's 190 milligrams per deciliter, in the absence of a family history of premature coronary disease in kids, or 160 milligrams per deciliter in the presence of a family history, is a sign that that individual may have FH. Family history of early heart attacks or heart disease. And then I'll show you some pictures. But those who have painful Achilles tendons, that's your heel pain, or bumps on the knuckles or elbows or knees, they're really not bumps, they're called xanthomas. But those findings may in fact suggest that someone has FH. And if you suspect it, you should talk to your provider. Now, I must also highlight the fact that familial screening for hypercholesterolemia is important. And that means that we must test kids of parents who have high cholesterol, recognizing that if a parent has FH, there's a 50% chance that that child has FH. Likewise, if a child has FH, there's also a 50% chance or one of the parents is affected. So I promised you I would show you some pictures. This is corneal arcus. This is cholesterol deposit in the eye, and this is associated with familial hypercholesterolemia. Likewise, on the opposite side, you'll see here xanthomas. These are cholesterol deposits in the eyelids, and these findings again are associated with FH. And you'd be surprised how many people walking around have these findings. I detected one in a colleague actually, and you come to find out this person, in fact, has FH. The important thing to note about FH is that it can also affect near the joints. You can see signs of swelling or tendon xanthomas near the Achilles or the knees or near the knuckles, and those too can be signs. But as I mentioned, many people have no outward display of FH, and it's only the lab values that let you know that the person has familial hypercholesterolemia. Now, I won't go into too much detail, but there are heterozygous forms, meaning mixed good and bad genes. So you have one good gene, meaning normally made LDL receptor, and one bad gene, meaning the LDL receptor may not be functioning normally in half of the case. Homozygous FH is when you get two bad genes, meaning both parents were affected and the child is affected and carries two bad genes with really no functioning LDL receptor. And that case is pretty severe. Those kids have LDLs of like 500 at 5 years of age. So I'm a pediatrician. I would be remiss if I didn't talk to you about screening for familial hypercholesterolemia in kids, understanding that there are recommendations. Recommendations include screening as early as 2 years of age if there is a known family history of premature coronary disease, and screening of all children. That's all children 9 to 11 years of age, and again at 17 to 21 years of age. And that's screening means a lipid panel. That means having a blood test drawn that tests the cholesterol. Family history, when we talk about family history, again, we're talking about a first or a second degree relative. That could be a parent or a grandparent who's had a myocardial infarction, stroke, or peripheral vascular disease, or coronary artery stent placement before 55 years of age in men or 65 years of age in women. We perform cascade screening and reverse cascade screening, which means if I detect that a child has FH, I will screen the parents. And if a parent is detected or determined to have FH, the children should be screened. Now, it's important also to note, how do we treat FH once detected? The treatment is a medication, and the first line of treatment is called a statin. Statins inhibit a particular enzyme that is a rate limiting step in cholesterol synthesis. So you decrease the amount of cholesterol made, but in effect, you're also helping to upregulate the ability to clear cholesterol. And there are many different types of statin. But why do we treat and why do we treat early? This is a complex graph, but I'm going to walk you through it. Along the x-axis, you will see age in years, starting from 0 and extending out to 60. Along the y-axis, you will see cumulative LDL-C. That's cumulative exposure to bad cholesterol. We all start at 0. However, if we look at those without familial hypercholesterolemia, the likelihood of having a hard cardiovascular event, denoted by this horizontal orange line, is protracted. It happens much later than if somebody has homozygous FH, where heart attack can occur as early as 12 and a half years of age, or heterozygous FH, where heart attack or heart disease could occur as early as 35 years of age. The importance of treatment are the green and the purple graphs, because what you see is that if we start treatment early, and this is around 9 years of age, we can approximate the same onset of heart disease as if someone did not have FH. But if we start treatment later in life, we're not as successful. So it really is important to start treatment at the time of diagnosis. And we begin statins around 7 years of age to 8 years of age, although we may wait until 10, depending on the severity. The way in which we dose statins has to do with the intensity. Low intensity is less than 30% reduction in LDL. Moderate intensity is 30 to 50%, and high intensity is greater than 50%. Dosing as well is related to the individual statin. And time of age of use is also related to the individual statin. So rosuvastatin can be started as early as 7, although we rarely do that. We usually wait until about 8 to 10 years of age. Some people fear statin complications such as myalgias or muscle aches, that those can occur. They're rare, but they can occur. In which case, we determine if we just need to change the dose or change the statin. But we also check other factors. We check liver enzyme levels. We also screen blood sugar, and we make sure that we manage the statin intolerance if present. There are some other therapies that are present and allow for us to manage cholesterol levels, and these include some traditional therapies like statins and Zetia, and there's some novel therapies that exist. And for cases of homozygous FH, that more severe form, there are in fact some additional therapies that are available. So I want to close by inviting you to review this case with me. So this is a 13-year-old referred to me for management of obesity as well as abnormal lipid profile. The diet was not the best, less than one serving of fruit per day, less than one vegetable per day. Um, Occasionally ran, but there was a strong family history of premature heart disease, maternal grandmother's sister, and mother, cholesterol's in the 400s, and they did believe that there were distant relatives who had premature heart disease. Now, looking at this child's lipid profile, you see the total cholesterol is 301 and the low density LDLC is 215. So remember our rule. If there was a family history of premature coronary disease, 160 is the cutoff. We allow the child to do 3 months of lifestyle improvement. The triglycerides, which were elevated before, normalized, and the good cholesterol improved. The HDL went up. But notice what happened with the total cholesterol and the low density lipoprotein. And the low density lipoprotein, they remained high. LDL remained 190 and total 254. This is the pattern of FH. LDL that's high, total cholesterol that's high. This child has what? If you guess familial hypercholesterolemia, you are correct. The child was tested as well. We did do genetic testing to confirm that the child, in fact, carried an LDL receptor mutation. We instituted statin therapy. We improved the cholesterol, the LDL levels. We also executed reverse cascade screening, and were able to identify multiple family members and to treat them and to refer them for treatment as well. So, in conclusion, FH is a treatable cause of premature coronary artery disease, and screening, though, is essential. Once diagnosed, it must be treated to reduce the risk for premature coronary artery disease. And it's preventable. It's preventable heart disease. I must say that again. It's preventable heart disease is associated with FH, but we must treat. I thank you for your time, and I hope you enjoy the rest of this session.
Hello, everyone. My name is Aisha Mustafa. I'm currently a cardiovascular disease fellow at Emory, and I'm thankful for the opportunity to speak to you all at the Association of Black Cardiologists Healthy Churches 2030 program on the important topic of hypertension, achieving adequate control to reduce the risk of cardiovascular disease. And so here are the objectives of my talk. I will start by defining hypertension or high blood pressure and speak about some important statistics. We'll talk about what blood pressure goals that we focus on. We will talk about the different strategies for blood pressure control, as well as some common challenges that patients and their physicians face with blood pressure control. And we'll end with some key takeaways. So, what is hypertension? Hypertension or high blood pressure is simply the pressure that blood exerts on the walls of the arteries. It's typically expressed as a ratio of systolic blood pressure, which is the pressure that blood exerts on the arteries when the heart contracts, over the diastolic blood pressure, which is the pressure that the blood exerts on the arteries when the heart relaxes. About 90 to 95% of individuals have what we call essential or primary hypertension, which is hypertension that's diagnosed in the absence of a secondary cause. What's important to note is that hypertension is one of the most common preventable risk factors for cardiovascular disease, which is an umbrella term for coronary artery disease, heart failure, stroke, myocardial infarction or heart attack, as well as end-stage renal disease. And amongst all these risk factors, hypertension is a leading cause of mortality and disability worldwide. And so, how do we define high blood pressure based on our guidelines? The 2017 American College of Cardiology, American Heart Association guidelines are the most recent guidelines that are utilized in the United States and is essentially an expert consensus of all things hypertension. Based on this guideline, stage 1 hypertension is based on a systolic blood pressure between 130 and 139, or a diastolic blood pressure between 80 and 89. Stage 2 hypertension is systolic blood pressure equal to or greater than 140 or diastolic blood pressure equal to or greater than 90. You can see here, based on this table, that blood pressure or hypertension diagnosis is also a spectrum. And so we have elevated or borderline blood pressure, which we define as systolic blood pressure between 120 and 129, and diastolic blood pressure less than 80. Diagnosis of hypertension is always based on an average of two or more readings on two or more occasions. And so, what's important to note is that you cannot diagnose hypertension or high blood pressure based on one isolated reading of high blood pressure. If there's one thing I want you to take from this talk, is that hypertension can be prevented and treated. It is a modifiable risk factor. We should focus on screening for hypertension and treating hypertension because this is something that is within our control. Just some more statistics for you. About 1 in 4 adults will have high blood pressure, and about 50% of those individuals are unaware of their diagnosis because oftentimes hypertension or high blood pressure is asymptomatic. Worldwide, about 3.5 billion individuals will have elevated blood pressure. So, as defined earlier, this is systolic blood pressure greater than 120, and about 874 million individuals will have what we defined earlier as stage 2 hypertension, which is a systolic blood pressure greater than 140. And it is important to understand that there are serious public health consequences to high blood pressure. And so, blood pressure that is not controlled leads to approximately 9.4 million deaths every year. Focusing specifically on the United States, we know that Black individuals will develop hypertension at an earlier age compared to white individuals. And on average, their systolic blood pressure will be 7 points higher than white individuals. We also know that Black individuals are more likely to have resistant hypertension when compared to white or Hispanic individuals. Additionally, Black individuals will essentially have greater suffering, greater mortality and morbidity from complications of hypertension, such as heart failure, stroke, end-stage renal disease. And basically, it's been estimated that approximately 50% of the excess stroke risk among Black individuals is as a result of uncontrolled hypertension. And lastly, the life expectancy of Black males and females with hypertension is extremely lower than the life expectancy of white males and females of the same age with hypertension. And so this is a serious problem amongst minority individuals. And just to drive home this point, this is a table here that is showing the prevalence of hypertension that's broken down based on sex, based on age, and based on race and ethnicity. And what the highlighted boxes are showing here is that the prevalence of hypertension increases with age. So what you see here is that individuals greater than 65 years of age have a higher prevalence of hypertension, and that individuals who are in the non-Hispanic Black category overall compared to other race and ethnicities amongst both men and women also have an increased prevalence of hypertension or high blood pressure. Common risk factors for high blood pressure, we typically think about as being modifiable, which means that it can be controlled or changed, or relatively fixed factors, which are typically beyond our control. So some of the modifiable risk factors that increase our risk for high blood pressure include current cigarette smoking or secondhand smoking. And with secondhand smoking, I think it's important to note that being exposed to other people who smoke, which counts as secondhand smoke, is a risk factor, even though the individual does not smoke. Other risk factors include type 2 diabetes, high cholesterol or high LDL, being overweight or obese, being physically inactive, and having an unhealthy diet. Some of the fixed risk factors that we think about include chronic kidney disease, family history, which is related to genetics, increased age, low socioeconomic or educational status, male sex, obstructive sleep apnea, and psychosocial stress. I wanted to highlight risk factors that are common specifically among Black or African American patients with hypertension. So, some of the risk factors that we already discussed, including genetics, environmental comorbidities, specifically obesity and chronic kidney disease, as well as specific psychosocial risk factors. I just wanted to highlight here one of the I think more important mechanisms of hypertension, which is the renin-angiotensin-aldosterone system or the RAS system. Um, the RAS system is a hormonal system that controls blood pressure and is essentially responsible for long-term regulation of blood pressure. And so when there is a drop in blood pressure, we have juxtaglomerular cells in the kidneys, which produce a substance called renin. Renin then converts a protein called angiotensinogen, which is produced in the liver, to angiotensin 1. And angiotensin 1 is converted to angiotensin 2 by the angiotensin converting enzyme, which is produced in the lungs and the kidneys. Angiotensin 2 is a hormone. It binds to angiotensin 2 receptors and is able to exert various effects in the body, such as stimulating vasoconstriction or narrowing in the arteries, which ultimately raises blood pressure. It leads to the production of aldosterone in the kidneys, which causes salt and water retention, and also acts on the brain to stimulate thirst, and also cause further retention of water with the production of antidiuretic hormone. And all this leads to an increase in blood pressure and blood volume. Where we have an issue is when the RAS system becomes overactive, and this is what causes hypertension. And so we have a lot of antihypertensive medications that specifically target this mechanism to help with treatment of hypertension. So we'll briefly talk about screening, diagnosis, and management now. And so hypertension, as we know, is mostly asymptomatic, and so a lot of the time is typically diagnosed when people go to the doctor, such as the primary care doctor or urgent care or different clinics. And so a lot of the diagnosis is made in the clinic setting. Um, and is typically based on repeat blood pressure measurements in the clinic setting. I just wanted to highlight how blood pressure should be measured either at home or in the clinic. So you want to make sure that the appropriate blood pressure cuff is used based on the patient's upper arm circumference. You want to make sure that the patient is well rested for at least 5 minutes. You want to make sure that they're seated upright with their legs touching the ground and not crossed. And we want to make sure that their arm is at their heart level when taking blood pressure. And with this, we are able to measure blood pressure appropriately. Since 2010, there have been other methods such as home blood pressure monitoring and ambulatory blood pressure monitoring that have been introduced as other ways to measure blood pressure and help us identify different hypertension phenotypes. And so, home blood pressure monitoring refers to the measurement of blood pressure at regular intervals by individuals in their home or elsewhere outside of the clinic setting, while ambulatory blood pressure monitoring is essentially the recording of blood pressure at regular intervals, typically every 20 to 30 minutes over a 24-hour period, while the individual goes about their daily activity. And the ability to measure blood pressure outside of the clinic setting has been really important in helping us recognize specific hypertension phenotypes, such as white coat hypertension or masked hypertension. And so, just to touch a little bit on these phenotypes, so a person with a normal blood pressure will have normal blood pressure both in the office or clinic setting and in the home or ambulatory setting. The most common phenotype of hypertension that we are all aware of is sustained hypertension. And this is when someone has high blood pressure in the office and clinic setting as well as when measured in the home or ambulatory setting. Now, maxed hypertension occurs when an individual has normal blood pressure in the office or clinic setting and high blood pressure in the home or ambulatory setting. While white coat hypertension happens when an individual has sustained elevated blood pressure in the office or clinic setting and normal blood pressures at home or in the ambulatory setting. So when there is a concern for masked hypertension or white coat hypertension, measuring blood pressure in the ambulatory or home setting is really important to establish these diagnoses. If an individual is diagnosed with white coat hypertension, meaning their blood pressure is elevated in office but normal in the home or ambulatory setting, then we focus on lifestyle modification for that patient and continued follow-up to monitor their blood pressure. Um, when a patient is diagnosed with masked hypertension, which means that their blood pressure is normal in the clinic or office setting and elevated at home, we still want to focus on lifestyle modification, but we want to make sure that we're treating their blood pressure as well with medication. So the goals of hypertension management overall is to lower blood pressure to target ranges and based on our guidelines, as mentioned before, that's less than systolic blood pressure less than 130 and diastolic blood pressure less than 80. We want to make sure with hypertension management that we're reducing cardiovascular risk. We want to ultimately improve the patient's quality of life. And we want to make sure that we're targeting hypertension management to the patient's specific comorbidities. Um, Overall, one of the cornerstones of blood pressure control is lifestyle management or lifestyle changes. And this table shows the extent to which different lifestyle changes can affect one's blood pressure. And so here you see physical activity is broken down into aerobic activity, dynamic resistance, and isometric resistance. We see that aerobic activity can reduce blood pressure anywhere between 5 and 8 points. Dynamic resistance um, which involves exercises with sets and repetition, can decrease blood pressure by up to 4 points, and isometric resistance can decrease blood pressure by up to 5 points. We want to focus on a healthy diet. The DASH diet is essentially the Mediterranean diet, rich in fruits, vegetables, whole grains, and low-fat dairy product, and this can decrease blood pressure by up to 11 points in individuals with hypertension. Weight loss can decrease hypertension by up to but can decrease blood pressure by up to 5 points. Reduced sodium intake, and typically what we recommend is less than 1.5 grams per day, can decrease blood pressure by anywhere between 5 and 6 points. And then alcohol reduction in alcohol consumption can decrease blood pressure by up to 4 points. Um, the important thing to note is that many times blood pressure cannot be controlled with lifestyle changes alone, and medications are often needed to achieve adequate blood pressure control. So I always set the expectation with my patients that oftentimes more than one medicine is needed. So in a survey of major clinical trials on hypertension, the average number of medicines needed for blood pressure control was about three. Oftentimes, we use a strategy of a combination pill, which typically contains two medicines at different doses to start with, especially when the patient has a systolic blood pressure that's greater than 20 points above goal or a diastolic blood pressure greater than 10 points above goal. So, just quickly, blood pressure medications. As you can see here, there are different blood pressure medications that can be used. The ACE inhibitors and angiotensin receptor blockers target the mechanism of the RAS system that I talked to you about earlier. Thiazide, diuretics, and calcium channel blockers are also popular options. Diuretics and beta blockers are used specifically for blood pressure control in patients with heart failure. We also have renin inhibitors and alpha 1 blockers. It's important to consider that blood pressure control can look different in different populations. We have research that shows that in Black patients with hypertension and without kidney disease or heart failure, thiazide, diuretics, and calcium channel blockers are the preferred medicines to use and are the cornerstone of medications for blood pressure control in Black or African American patients. We want to make sure that we are treating conditions that can worsen the control of blood pressure, such as obesity, obstructive sleep apnea, and chronic kidney disease. We want to make sure that we are working patients up for secondary causes of hypertension once hypertension is diagnosed. This is just a summary of everything we talked about, including non-pharmacologic, pharmacologic, management of blood pressure as well as treatment of comorbidities. Um, so there are challenges in achieving adequate blood pressure control, and one of the biggest challenges is medication non-adherence. Patients may lack awareness or of their diagnosis, and there are also socioeconomic and access-related issues such as poverty, unemployment, illiteracy, or inability to afford medicines that are more prevalent among African American and Hispanic populations. In general, some of the strategies that we use to improve blood pressure control includes patient education, regular monitoring of BP in home and office settings. We want to make sure that we're improving access to care and using an interdisciplinary approach, which typically involves physicians, pharmacists, and social workers, as well as care coordinators to make sure that patients are getting all the resources they need to afford their medications and take their medications. We also want to make sure that we're essentially doing community outreach in diverse settings, including barbershops, beauty salons, churches, and these strategies have been successful in Black populations. So just key takeaways to end this talk. Hypertension is a major modifiable risk factor for cardiovascular disease. We know that achieving target blood pressure levels significantly lowers cardiovascular risk. We know that lifestyle changes, lifestyle management are foundational for blood pressure control. We know that medications are often necessary for adequate control, especially in high-risk individuals. Addressing barriers to treatment, such as medication non-adherence and psychosocial factors, are crucial. And then regular monitoring and follow-up of patients, both in the clinic setting and monitoring of blood pressure at home, is critical for sustained blood pressure control. Thank you.
Hello, my name is Sabrina Islam. I'm a preventive cardiologist at the Lewis Katz School of Medicine at Temple University. I would like to thank ABC for the opportunity to speak to you today about this very important topic. Today, I will be talking to you about the role of coronary artery calcium scoring as a tool for cardiovascular risk assessment. I have no disclosures to report. Coronary artery disease develops with the buildup of plaque within the coronary arteries, which are the major arteries supplying blood and oxygen to the heart. Plaque is made up of a combination of cholesterol, fat, calcium, fibrin, and cellular waste, among other substances. Over time, plaque deposits within the lining of the coronary arteries, causing them to stiffen and harden through a process called atherosclerosis. As we can see in the diagram of a cross-section of a blood vessel, the plaque can remodel over time and can become more extensive and complex, leading to narrowing of the major blood vessels. Chronic plaque can remodel as coronary calcifications, which we are able to detect and monitor over time by a coronary artery calcium score. We know that it takes a long time for plaque to develop into coronary calcifications. Thus, higher scores are a marker of long-standing soft plaque deposition and are associated with higher cardiovascular risk. Lower scores correspond with either lower burden of plaque or less chronic plaque deposition and lower cardiovascular risk. So what are some of the risk factors for developing coronary artery disease, and how can we modify these risks? There are a number of traditional cardiovascular risk factors, which include chronic medical conditions such as high blood pressure, high cholesterol, diabetes, and obesity. Other factors that should be assessed include physical activity, diet, family history of cardiovascular disease, and tobacco use. It is important to assess the status of each risk factor, including addressing the social determinants of health impacting them. The risk factors should be modified to minimize overall risk to an individual. For example, those with high blood pressure should monitor their blood pressure to ensure they are well controlled and at goal with medications and/or with lifestyle modifications, such as maintaining a low sodium diet, getting adequate sleep, as well as utilizing stress reduction strategies. Exercise and physical activity should be encouraged to improve cardiovascular conditioning and fitness. Modifying these risk factors can help reduce the deposition of plaque and ultimately reduce the development of coronary calcifications. So after reviewing an individual's cardiovascular risk factors, we are able to determine their risk of developing atherosclerotic cardiovascular disease, also known as ASCVD, using a risk calculator. These are the components of the ASCVD estimator, which include age, sex, race, blood pressure, cholesterol levels, history of diabetes, high blood pressure, tobacco use, and medication use, including statin and aspirin therapy. When we take these risk factors into consideration, we're able to estimate someone's 10-year risk of developing atherosclerotic disease. We are also able to get an estimate of lifetime risk of developing ASCVD. The risk calculator is also able to estimate the risk of developing ASCVD with optimization of each modifiable cardiovascular risk factor and is helpful in guiding treatment and management strategies. According to the American Heart Association and American College of Cardiology's 2019 guideline on the primary prevention of cardiovascular disease, we can utilize the estimated 10-year ASCVD risk to stratify individuals into different categories. Based on these categories, we're able to determine what therapies or risk reduction strategies to utilize. We can see that cardiovascular disease risk is broken down by age range, baseline risk factors including diabetes, elevated LDL cholesterol above 190, and presence of risk-enhancing features such as chronic kidney disease, inflammatory diseases, and elevated laboratory tests such as triglycerides, CRP, lipoprotein A, and ApoB. Additionally, we see that for those between age 40 to 75, with an LDL between 70 to 190, without diabetes, a risk discussion should be initiated with these patients to determine whether to start lipid-lowering therapy. Particularly in the borderline and intermediate risk individuals, with estimated 10-year risk between 5 and 20%, a coronary artery calcium score can provide more guidance regarding appropriateness of pharmacotherapy. For those with a score of 0 and no additional risk factors, statin therapy might be deferred. For those with higher risk or higher risk percentile, statin therapy should be strongly considered. So what is a coronary artery calcium score? A coronary artery calcium score is measured by performing a CAT scan. The scan typically requires a low dose of radiation, no contrast, and is completed in a short amount of time. An ECG is generally performed as part of the test. The scan can detect the presence of calcium within the coronary arteries. The result is reported as a coronary artery calcium score and percentile based on age, sex, and ethnicity. Thus, this short and low-risk procedure can be a very powerful tool to understand an individual's cardiovascular risk and can help determine whether early preventive strategies can reduce downstream cardiovascular events. As we see here, the results themselves are presented as absolute coronary artery calcium score or Agatston score. Additionally, a MESA-based calcium score adjusted for sex, age, and ethnicity is reported as a percentile. They are often broken down into further categories based on the score. So an absolute CAC score of 0 indicates there is no calcium visualized in the coronary arteries and can be interpreted as a very low risk for developing cardiovascular events in the future. Additionally, having a 0 percentile reporting is a very low risk for coronary disease events. Individuals with a CAC score greater than 400 and a corresponding MESA-based CAC percentile greater than 90 have a high probability of myocardial ischemia and future coronary events. For those with moderate score ranges, they are at elevated risk for future coronary events. If their baseline ASCVD risk was estimated to be moderate risk, this may reclassify them as being high risk. In this schematic, we can understand how CAC scoring can be used to help understand an individual's risk of future coronary events and further subclassify individuals based on additional risk factors. We can pair it with traditional risk factors and traditional risk scores. We can further break down individuals into subgroups based on their baseline characteristics, the burden of risk factors they carry, the score itself, and the distribution of calcification within the coronary arteries, noting in particular whether or not there is involvement in the left main coronary artery. In this way, we're able to combine traditional cardiovascular risk factors and the CAC score to perform a more comprehensive risk assessment. This is the multi-ethnic study of atherosclerosis, MESA, 10-year coronary heart disease risk with CAC calculator. This calculator was developed to reassess the 10-year cardiovascular risk of individuals who have a CAC score available to help re-stratify their risk. We see in this example that an individual who was estimated to have a 12.7% 10-year risk of coronary heart disease was reduced to a risk of 3.5% due to a CAC score of 0. Thus, the calculator helped reclassify the individual as low risk, which can be used in the risk reduction discussion when determining whether to initiate pharmacotherapy in addition to other risk modification strategies. When taking all of this information together, we can come up with this integrated schematic. Here we see that younger individuals typically only have evidence of coronary artery intimal thickening and undetectable CAC scores. We can see that with age, pathologic intimal thickening and corresponding microcalcifications can develop, which are considered more unstable plaque types. The plaque can become more complex and develop calcification with advancing age. We can see from tissue specimens that the distribution of calcium becomes more diffuse with age, which has also been noted by other imaging studies such as CT scan. This leads to a rising CAC score and more diffuse coronary artery disease. With lower CAC score, individuals typically have single or two-vessel coronary artery disease, and with higher scores and more diffuse distribution of calcium in the coronary arteries, individuals often have multivessel coronary artery disease and may develop additional cardiac conditions and symptoms such as heart failure. Thus, reviewing CAC score data can be a useful tool to initiate treatments to stabilize cardiovascular disease prior to a coronary heart event occurring. Here is a proposed guideline for statin-based therapies using the 10-year ASCVD risk estimator and CAC score. As discussed, we note that higher 10-year risk and higher CAC scores can correspond to higher risk for developing coronary heart disease and having a cardiovascular event. We see in this table that those deemed to be at very low risk, no statin therapy is indicated. Most importantly, in those with borderline risk and intermediate risk, if the CAC score is 0, statin therapy might not be recommended as well. We see how in this range, certain individuals may be started on therapy, whereas others might have indications to come off statin therapy. So in conclusion, it is important to have a comprehensive approach to cardiovascular risk assessment. We should review modifiable and non-modifiable risk factors for developing coronary artery disease and use it as an opportunity for intervention through risk factor modification strategies. The coronary artery calcium score is an important cardiovascular disease risk stratification tool. We can further stratify and reclassify individuals who were previously thought to be at borderline or intermediate cardiovascular disease risk using traditional risk factors. A score of 0 is a very powerful negative predictive risk factor for the development of coronary heart disease in the future. In patients with an elevated score, particularly in conjunction with traditional risk factors for coronary artery disease, initiation of pharmacotherapy should be strongly considered, in addition to risk factor modification strategies. There are a number of great resources that can be utilized to further understand the role of calcium scoring in coronary heart disease prevention. These resources include more information about the utility of CAC scoring and questions to ask your healthcare provider to see if this is an appropriate study for you. The American Heart Association, the American College of Cardiology, the National Lipid Association, among other cardiovascular societies, have resources at the links provided. This is an infographic from CardioSmart from the ACC, briefly outlining CAC scoring and providing links to additional resources. Here we have an infographic from the National Lipid Society reviewing the role of CAC scoring and breaking down recommendations by risk categories as for lipid-lowering therapies and consideration for initiation of aspirin therapy in those at low bleeding risk. Thank you for your time, and thank you again to ABC for allowing me to speak on this important topic.